Okay, enough from me. It is my pleasure to welcome Dr. Rebecca Simmons. Rebecca Simmons, PhD and MPH, is a research assistant professor at the University of Utah in the Department of Obstetrics and Gynecology. Dr. Simmons directs the evaluation for Family Planning Elevated and works on other implementation research, including her Salt Lake. Her research interests and expertise include fertility awareness-based methods, comprehensive contraceptive access, health technology, and implementation science. Dr. Simmons, I'm handing it over to you.
Awesome. Thank you, Alex, for that. Let me just take you over to my screen. And start out. So, thanks everybody for showing up today. I'm really excited to talk to you about knowledge-based methods of contraception, and I have to confess that the title of my presentation is a lie. You are not going to learn everything you always wanted to know about these methods in a 1-hour session, but hopefully I haven't burst your bubble too much and you'll stick around and learn some of the most important things about these methods. So ideally today we're going to cover an overview of knowledge-based methods, the basics of fertility awareness-based methods, some basics on lactational amenorrhea, and some basics on withdrawal. I'm also hopeful that we'll have some time to answer any questions that you might have. And if you do find that you have questions as I'm going through my talk, please type them into the chat box or feel free to speak out if you like. We can go over them in real time, or if we don't have time, I'll save them till the end, depending on how things go. So hold on, I'm gonna make sure that I can see all of the chat box. Perfect. So first of all, let's talk about what knowledge-based methods are, since this term isn't necessarily familiar to some of you. All methods require a certain amount of knowledge, but the term knowledge-based methods was coined specifically for methods whose success relies on the user having enough information about their bodies and fertility to subsequently modify their behaviors and decisions in order to support pregnancy prevention. Technically, a knowledge-based method doesn't require anything other than know-how, but in reality, most people use knowledge-based methods with other methods. So in the world of family planning professionals, knowledge-based methods are not beloved. So go on any website, including family planning organization websites, and you'll see a lot of stigmatizing language about these methods. And that message has gotten through to the public. And what we're finding is that many people underreport using these methods to public health and clinical professionals because they don't want to be shamed for using them. So why? Why do knowledge-based methods get such a bad rap? There are some legitimate reasons, and one of them, and I'm just going to get this out of the way up front, is that a lot of people disregard these methods because of the perception that they are much less efficacious than other contraceptive methods. So I'm going to discuss the efficacy of each of these methods in more detail when I talk about them individually, but I just want to get the issue of efficacy out of the way up front. Compared to some other methods of contraception like IUDs or implants, these methods do have lower efficacy. However, many of these methods have comparable perfect and typical use efficacy to other hormonal methods like the pill, the patch, or the vaginal ring. So this perception of terrible efficacy is largely because both family planning professionals and the public have been subject to myths and misinformation about these methods. For example, people commonly believe the term fertility awareness-based method is just a synonym for the rhythm method, rather than a description for a class of methods. And in fact, this belief was so prevalent that the CDC refused to change the efficacy information about FABMs on their website until last year in 2019. And up until that point, the typical use efficacy that they had listed for FABMs on their website was 76%, which is the efficacy for the rhythm method, despite the fact that many FABMs have typical and perfect use rates that are much higher. Similarly, Withdrawal has been considered a traditional method and has been lumped together with things like teas or herbal remedies in global classifications of family planning use, despite the fact that it has perfect and typical use efficacy. These types of misclassifications and groupings reinforce the idea that these methods aren't real, aren't effective, and are bad options for pregnancy prevention. Additionally, there are serious implementation barriers around these methods. So use of knowledge-based methods requires people to have a certain amount of health and body literacy or knowledge. In a country, and particularly a state where sex education is low, people's reproductive health literacy is also really low. These methods require more education and training than other methods, and some of them, like FABMs, often mean that people have to unlearn things they were taught, like the idea that you can get pregnant at any point in your cycle. Further, these methods are a skill set that once they're taught doesn't really make anyone any money. So there's no pharmaceutical rep out there making sure we've all had our symptothermal training, and there aren't any lactational amenorrhea commercials. So as such, our advocacy for these methods is a lot lower than other contraceptives that have that pharmaceutical support. Another issue that people bring up is the involvement and reliance of another person in order to use knowledge-based methods successfully. So for FABMs and withdrawal, a person who can become pregnant needs to have a supportive partner willing to change their behavior during sex in the fertile time in order to successfully avoid a pregnancy. And for lactational amenorrhea, a parent needs the support of the new infant who should be able to successfully breastfeed and do it often in order to maintain amenorrhea. And this reliance on other people sometimes gives some folks pause about these methods. Additionally, there's a perception that knowledge-based methods aren't methods that people want to use. And this can be reinforced by the fact that few clients are asking their providers about these methods. And due to the fact that these methods don't require a provider, the population of people who are actually coming through the clinic to ask about these methods might be different than the population of people who are actually using these methods. Finally, I just want to point out that these methods are sometimes seen as methods of last resort. There is some evidence that poverty and lack of insurance, low education, and coercion can be reasons that people use these methods in certain circumstances. And I believe very strongly that while these are valid method choices, every person deserves to have the full range of methods available to them throughout their reproductive life. So my intent on discussing these today is to add these methods to the menu rather than making them the main meal that we have. So on the plus side, why would we care about knowledge-based methods? So like I just said, the reproductive lifespan is 30 plus years, and we are fooling ourselves if we believe that any one method is going to fulfill all of a person's needs throughout their reproductive life. People need different methods to respond to different circumstances and goals, and more method choice is associated with more successful use and higher method satisfaction. Additionally, there's evidence to suggest that use of these methods is increasing. So trends for both fertility awareness methods and withdrawal are ticking upward, particularly over the last decade. For example, a recent analysis of the National Survey for Family Growth found that approximately 3% of women reported using a fertility awareness-based method in the past month. And this amounts to more than 1 million women and doesn't necessarily account for people using things like fertility apps. Similarly, a study of withdrawal rates found that about 12% of people listed using withdrawal as the contraceptive method that they used at their most recent sex act. But when they were asked whether a person had ejaculated outside of the vagina during their most recent sex act, more than 20% of those same survey respondents reported yes. So this indicates that both the way that we measure withdrawal and the way that people view withdrawal might be misunderstood, and that prevalence rates for this method are likely higher than we think they are. Rates of withdrawal are also found to be increasing among adolescents, similar to what's been seen in the adult population. And yeah, this data is only for vaginal penile sex. That survey was actually asking about those responses were for different sex partners. So another reason that you should care about knowledge-based methods is that even though these methods don't require providers to use them, providers still remain a primary trusted source of health information for most people, including people who use these methods. So even if they don't need you, they might want you. And if you can demonstrate your knowledge and willingness to support them, it's likely clients may want your expertise and help on this. So in turn, that education and expertise can improve efficacy rates for these methods. A recent study conducted on contraceptive efficacy rates using that same National Survey for Family Growth found that typical use efficacy for most contraceptive methods has improved over the last 20 years, with the exception of withdrawal. And I think this is likely because providers and educators are doing a better job teaching their clients about how to use methods correctly. So you have the chance to support better use of these methods as well. These methods are also important options for people who otherwise wouldn't choose to access contraception. So people with strong religious convictions or who have cultural challenges to using contraception might be more open to knowledge-based methods than other methods. So a study that I was involved in looking at new users of the CycleBeats app, which is the app-based standard days method across 7 different countries, found that 64% of these CycleBeats users hadn't used any other method of contraception in the past 3 months before they started using this app, and 24% hadn't ever used another method of contraception before starting to use this app. So improving the availability and acceptability of these methods can better support these populations. Finally, these methods have fundamental benefits to them. They emphasize improved body literacy and comfort with one's reproductive health. None of these methods have side effects. They are low or no cost, and they are easy to stop if there are issues. So there are lots of reasons why a person might choose to use a knowledge-based method. And now that I'm sure I've sold you on that, let's go over some specific methods. So the first one I want to talk about is fertility awareness-based methods. There are a lot of names for these methods, including fertility awareness-based methods, fertility awareness methods, natural family planning, and the rhythm method. And bad terminology is part of the reason so many people have misinformation about these methods. So I just want to clarify a few important things. The most up-to-date term to use when referring to these methods is fertility awareness-based methods or fertility awareness methods. I'm going to probably call them FABM in this talk just because the term is a mouthful. It's important to realize that FABM represents multiple methods rather than just a single method. So me referring to FABM would sort of be like me referring to hormonal methods when I talk about pills, patch, ring, shots, levonorgestrel IUDs, and Nexplanon. It's a helpful grouping, but it doesn't really give you any details about any of the actual methods in this group. So if somebody says that they're interested in a fertility awareness method, there are about a dozen actual methods to choose from within this group. So all fertility awareness-based methods are based on 2 common assumptions. The first assumption is the idea that there is a limited time window every cycle wherein a person can become pregnant. So this is what a typical menstrual cycle looks like. There's a follicular phase, which starts on the first day of menstruation and continues until the pre-ovulatory luteinizing hormone surge, which then stimulates egg release. There is an ovulatory period, which refers to the 32 to 34-ish hours after that LH surge, wherein the egg is released into the fallopian tubes and the ruptured follicle forms a corpus luteum, which produces progesterone, causing the uterus to thicken and prepare for fertilization. And then if that egg is not fertilized during the 12 to 24-hour period after its release, it dissolves and the corpus luteum degenerates during that luteal phase. So as progesterone and estrogen recede during the luteal phase, the top layers of the uterine lining start to break down and then are shed through menstrual bleeding. And fertility awareness methods use signs and symptoms to identify the fertile window, which is those 5 or so days prior to ovulation plus the ovulation period. And if a person can identify when they're fertile each cycle, they can avoid pregnancy by either avoiding or having protected sex during that fertile period. So fertility awareness methods, to be a fertility awareness method, they all must have rules about how to identify the fertile window. So some methods have more rules than others, but in order to classify as a method, there have to be person-specific signs or symptoms that inform whether that individual is in their fertile period. So this is a list of the main fertility awareness methods out there that have been studied for contraception. I haven't included any methods here that haven't had at least moderate quality efficacy trials done on them. You'll note that I've listed the types of signs and symptoms that each of them collects. And the perfect and typical use efficacy listed here are a range, since there are differences between the methods listed in each category. For example, there is a Marquette method, which uses the menstrual cycle length, luteinizing hormone strips, and cervical mucus, while Persona just uses the menstrual cycle length and LH strips. So you'll note that for some of these methods, both perfect and typical use efficacy are comparable to hormonal methods. And for others, there's a very large disparity between perfect and typical use efficacy. So for a better overview of efficacy of these different methods, I would recommend the systematic review conducted on these methods that came out in 2018 in the Journal of Obstetrics and Gynecology. And we will send that paper out as a reference after I finish with this talk. So you'll note that each of the different methods collects one or multiple signs and symptoms, and there are rules about how to collect and interpret these depending on what method is being used. For example, all FABM methods that collect cervical mucus agree that a person should check for cervical fluid throughout the day by wiping across the vulva using a piece of toilet paper after using the toilet. However, the 2-day method doesn't distinguish between the types of cervical mucus, whereas the symptothermal and the Billings method require a user to be able to distinguish between peak and non-peak mucus types by actually touching that mucus. I'm not going to go into the specifics of each fertility awareness method today because that would take a lot longer than we have. I just want to point out that there are many methods that live under the FABM category. Just like a pill, patch, or ring might be good for different people at different points in their lives, different FABMs might fit different needs or different values. So if you're interested in learning more, we can send out some links for folks who want to do a deeper dive into these methods and understand some of their finer points. For the most part though, you don't need to be an expert on FABMs to help someone select them as a contraceptive method. And there are a few things that I recommend to be discussed if a client is interested in using an FABM. So the first thing is to discuss where and how they want to get information about their fertility. So sorry, before I go on, Sarah says, I always thought that the BBT method was not that effective because intercourse before the BBT peak can still result in pregnancy. By BBT, are you talking about the symptothermal method or are you?
Yes.
Okay, so the symptothermal method collects 3 different signs and symptoms. It collects cervical fluid, it collects your basal body temperature, and it utilizes your past cycle history. And so when a person is utilizing the symptothermal method, they use BBT to confirm that ovulation has occurred. But the rules for application rely on cervical fluid and previous cycle data and BBT.
So methods that just use the temperature are less effective, much less effective than the combined.
Right, and there aren't actually any methods that I've listed here that only use BBT. So, and that's exactly why, because BBT only confirms that ovulation has happened. So a person couldn't rely on it to identify when they were in their fertile window. They could only rely on that temperature shift to understand when they were out of that fertile window.
And it seems like a lot of people are familiar with that, just the temperature spike.
Right.
So it's
right.
important to educate probably about that.
Yeah, and if somebody says that they're interested in utilizing BBT, it's important to talk to them about what other aspects that they might need to utilize in order to identify their fertile window. So for example, natural cycles is a basal body temperature plus method. So they have a thermometer that you utilize, but then they also have an algorithm that collects past cycle data in order to give you a fertile window that's based on both your BBT and their algorithm. So even that one, which is the closest that I've seen to a solely BBT method, isn't really a solely BBT method.
Thank you, that's helpful.
Yeah, of course. So the first counseling tip is really to talk about where and how a person wants to get information about their fertility. So FABMs really fall into two categories. They are either user decision methods or decision support methods. So some FABMs are user decision methods where the person uses their education and knowledge about the method to interpret their own signs and symptoms and determine whether sex is likely to result in a pregnancy that day. So other FABMs like standard days or dynamic optimal timing, persona, or natural cycles take user data and they provide the estimations of risk. So the user isn't making the decision on their own, an algorithm or a rule is telling them what to do. So user decision FABMs are really great for people who want to use FABM to learn a life skill, to become more in touch with their body, and who have the time and patience to go through the training that's required to gain that expertise. And additionally, some of these methods are more flexible for people who have cycle irregularities because a good trainer can help a person identify patterns of fertility specific to that individual. So generally, a user decision FABM can take anywhere from a couple of hours to 3 or so months before a person is able to use the method without needing backup. Symptothermal methods, which are some of the most effective FABM methods, also take the longest to learn, and often a person will need to factor the cost of that initial training into their method decision making. People who are interested in decision support methods will input information into either an app or a decision tool, and that tool will tell them what their risk of pregnancy is for that day. And because an outside source is determining the risk, these methods are generally easier to learn, and training can generally either be done in the app or the tool or with some very minimal oversight. But one of the drawbacks to these methods is that they are less appropriate for people with cycle irregularities or changes, so fewer people might be eligible to use them. And it's important to note that even though somebody might be able to learn one of these decision support methods more easily, education is still really important. For example, ensuring that somebody understands the difference between what spotting is versus menstruation would be really important when using an algorithm method that relies on period start date. So this is an important conversation to have with somebody who's interested. The second thing would be to have a conversation around efficacy. So as we've seen, there's often a fairly large gap between perfect and typical use efficacy of some FABMs. And when talking to clients about these methods, it's appropriate to note that their efficacy can be similar to those of other contraceptive methods, but it's also really important to note that these methods are less forgiving than other methods. So the importance of following the rules of each method as closely as possible should be stressed, and making sure that the client really knows what those rules are. Discussions around contraindications. So FABMs are generally not appropriate for people with underlying reproductive health challenges like endometriosis or PCOS, which might make identifying the fertile period difficult. If a client who has these issues is interested in using an FABM, it's definitely recommended that they use a multi-sign and symptom method, such as the symptothermal method, and that they work with a certified trainer. Additionally, if a client is coming off of hormonal contraception, it's important to advise them that they should have at least 3 menstrual cycles before they begin to rely on an FABM, just because cycle changes can take a while to kind of sort out after coming off of a hormonal method. So then asking about plans for sex during the fertile window. If a client notes that they are going to practice abstinence during the fertile period, it's a great time to provide a handout or have a conversation about non-intercourse sexual activity. Products like dental dams could be offered for clients who are interested. And then people who plan to have protected sex during the fertile window could benefit from discussions about what backup methods they'd like to use during the fertile period. So conversations around diaphragms, cervical caps, condoms, spermicides, and withdrawal are all possibilities if the client wants. So providing the client with these dual method options is an important component of FABM provision, but it's also important to note to the client that efficacy rates are then reliant on the barrier method and the FABM. So then asking about partner support. So asking what a client's plans are during the fertile period can further conversations about additional needs, including whether the client has talked to their sex partner about their plans to use fertility awareness methods and whether their partner is supportive of their decision. If they note that they have a supportive partner, you can ask if there are any resources that their partner might want that you can send home with them, like condoms or information about withdrawal. And then if a client reports that they have an unsupportive or wary partner, discussing specific reasons for that lack of support or wariness is important, as the partner might just have concerns about the efficacy of the method that could be addressed or supported, or they could be coercive or abusive. So FABMs are contraindicated for people who don't have control over their sexual activity. So additional discussion would be needed about the reasons a client in this situation might choose to use these methods. For example, some reasons a client might choose to use these methods in that type of situation would be if a person's partner doesn't want them to use contraception at all, an FABM could be seen as a way to at least know one's risk of pregnancy. So discussions about backup methods, prescriptions for alternative methods, and offerings of emergency contraception would be appropriate, as well as providing other resources for folks experiencing abusive relationships. And then discussing support during the learning phase. It's really good with all knowledge-based methods to let people know that these methods take a little bit of getting used to. So taking one's temperature at the same time every morning, or remembering to check for cervical mucus, or even remembering to check whether it's a fertile or infertile day before having sex, can be things that take getting used to for both people and their partners. So offering preventive prescriptions for EC as a backup alongside other methods can be a good thing, although it's important not to assume that all clients are going to want these. So if a client does accept EC as a prescription, let them know that if they use it, their current and next cycles might be disrupted because of the EC. So cycles might be longer or shorter than usual, and periods might be longer or shorter than usual. And if they took EC prior to ovulation, they should use a barrier method until their next menstrual cycle, since EC might delay rather than prevent ovulation for some people. So finally, just for me, encouraging the use of appropriate apps and devices. I would ask clients what fertility technology they plan to use. So there are more than 1,000 health apps out there that currently claim to track fertility, but the vast majority are based on incorrect or blatantly false information. So I'm going to provide more details about fertility tech tomorrow in a separate webinar if you're interested. But as a brief summary, if a client is using an app to track their fertility, make sure that they are not relying on any information about ovulation or the fertile window unless the app has undergone efficacy testing. So there are very, very few apps that have undergone this type of testing, and it's really good to note that while an app can be a helpful tracking device, unless it's been reviewed and approved, don't take its advice on whether you're fertile or whether you're going to ovulate. So that's a brief summary of FABMs. If anybody has any questions, I'm happy to answer them now or later. And if nobody has any other questions, I will move on to talking about lactational amenorrhea. So,
can I ask one question before you move on?
Oh, absolutely, you can.
I should know this, but we have part of the FPE options, we have like an app, right?
Yep.
Can you just remind me what that is?
Yeah, so that app through FPE is the Natural Cycles app, and FPE covers the app subscription. I think the subscription is like $12 a month, and the BBT thermometer that Bluetooth pairs with the app. So a person who's interested in using Natural Cycles can get that subscription for a year to the Natural Cycles app, as well as that thermometer through the FPE program.
And the boxes we have, I haven't opened them. Do they have the thermometer in the box?
Yeah, they've got the thermometer, and I believe they should have the code for the subscription in there as well.
Awesome. Thank you.
Yeah, of course. So the next knowledge-based method is lactational amenorrhea. And lactational amenorrhea is a method where a person can prevent pregnancy by breastfeeding. So the concept of using breastfeeding to prevent pregnancy has been around for a really long time, but the approach to LAM, along with the mechanism of action and the rules for use, were developed in partnership with the WHO in the 1990s. So the way that it works is frequent breastfeeding disrupts the gonadotropin releasing hormone rhythm, which then affects the HPA axis, reducing luteinizing hormone, which then disrupts follicular development and thus suppresses ovulation. So lactational amenorrhea has 3 criteria that need to be met in order to use it according to the rules. So first, the baby should be fully or nearly fully breastfed. So nearly fully means that more than 75% of the baby's feeding occurs on the breast. And then breastfeeding needs to occur at least every 4 hours during the day and every 6 hours at night, and more when the infant is a newborn. There isn't a ton of research on the impact of self-expressing milk or pumping, but the existing evidence suggests that it's less effective than breastfeeding, likely because the hormones produced during breastfeeding aren't produced during pumping, like oxytocin. So next, in order to use this method, the person needs to be amenorrheic. While some bleeding and spotting are to be expected in the first 2 months postpartum, any bleeding or spotting that occur after 2 months should be considered evidence of ovulation returning, and this method would need to be stopped. And then finally, this method is only recommended for the first 6 months postpartum. Generally, infants begin complementary feeding around 6 months of age, which translates into fewer calories needed from breast milk and thus less breast milk production and feeding. So 99 out of 100 people avoid pregnancy for 6 months if all criteria are perfectly adhered to. Typical use efficacy is 98 out of 100 people during that 6 month time frame. However, if the breastfeeding parent works outside the home, typical use efficacy reduces to about 95 out of 100 people during that time frame, even if the working parent is expressing milk every 4 hours. So it's just something to let people know about. So counseling for LAM, now that we've talked a little bit about how you use this method, some counseling tips, ensuring the client knows the rules for LAM before birth. So like any contraceptive method, discussing choosing LAM can occur before birth. And in order to use this method, people need to be adhering to it basically from the get-go. So ensuring clients know the guidelines before birth can help support people who want to use this method, make sure that they're prepared for what that entails. Helping manage expectations to reduce shame and stigma on the new parent. So for people who are giving birth to their first child or who are trying LAM for the first time, I think it's important to have alternative option discussions as well. So many people have intentions to solely breastfeed, but because there are so many variables that are external, it can be really helpful to minimize the shame that can be associated with not being able to successfully breastfeed for LAM in the event that life just doesn't allow for that. So talking to clients about what other methods they would want and potentially prescribing them an alternative in the event that something doesn't work out with lactational amenorrhea can ensure that this isn't just one more decision they need to deal with after they're giving birth. And then offering emergency contraception, offering a prescription for EC or actually providing EC has been found to improve pregnancy rates among LAM users. So you can mention that EC can be helpful in the event that something suddenly stops working, including things like a job change that doesn't allow for breastfeeding or a change in infant feeding patterns. And then discussing a transition plan. So discussing options and desires for contraception after the 6 months can also take place when talking about LAM. People might change their minds about what they would want later on, but at least there's an option already in place to transition from LAM when they need to. Does anybody have any questions about lactational amenorrhea? Great. We'll move on to withdrawal. So last but certainly not least, withdrawal, also called the pull-out method, is just that, pulling out the penis before ejaculation in the vagina. I think it's the OG of contraceptive methods because it has been around since basically forever. As I have mentioned earlier, recent studies have shown that we've likely underestimated how common withdrawal is because we really haven't been measuring it correctly, and that rates of withdrawal are likely increasing. It appears that many people are using withdrawal in conjunction with other methods, so like withdrawal and the pill or withdrawal and a condom. And that being said, with efficacy rates of withdrawal are the only efficacy rates that have not improved over the last 20 years. And my hypothesis is that this is because we don't teach people how to use withdrawal correctly. So despite seeming fairly straightforward, withdrawal does have some rules for use. First, it's recommended that the person with the penis urinates before each sex act to clear the urethra of any residual sperm from prior sexual activity, including things like masturbation. So, and then next, the person who ejaculates needs to do something so completely away from the vagina or the vulva so that no semen is exposed to the female reproductive tract. Withdrawal is not appropriate for people who do not have the ability to control ejaculation. However, learning to control ejaculation is a skill that can be practiced, and there's some evidence that the longer people practice withdrawal, the better they are at controlling ejaculation. So like other knowledge-based methods, it is perfectly okay to practice withdrawal prior to relying on it to avoid pregnancy. People who are interested in using withdrawal can gain better control over ejaculation by masturbating until almost at the point of orgasm and then stopping, waiting for 30 seconds and then masturbating again. Or they can practice by using condoms and attempting to withdraw with the condom on. So in the past, there has been some controversy about whether sperm can be found in pre-ejaculate fluid. Two small but well-done studies have shown strong evidence that some people have small amounts of live sperm in their pre-ejaculate fluid. So a 2011 study found that about 12% of participants had live sperm in their pre-ejaculate fluid, and a subsequent 2016 study found that about 16% of participants had live sperm in their pre-ejaculate fluid. And it really seems to be like an either-or situation. So either you're a person who does or you're a person who doesn't, and that seems to be consistent. But since we're not really going to test pre-ejaculate fluids for sperm content, people who are using or interested in using withdrawal should just be told that there's a small possibility that they could have some sperm in their pre-ejaculate fluid. So in the event that a person is able to practice withdrawal perfectly, 96 out of 100 people will successfully avoid pregnancy over 12 months. And this is really comparable to the external condom, which has an efficacy rate of 97 out of 100 people. However, as I mentioned earlier, typical use efficacy of withdrawal is currently lower, sitting at about 80 out of 100 people successfully avoiding pregnancy over 12 months. And again, I would bet that these methods could be raised if withdrawal were seen as valid, if it were taught like other methods, and if it were used with other contraceptive methods like EC or FABMs and condoms. So let's talk about some counseling tips for withdrawal. First of all, just be kind. If someone is brave enough to admit to you that they are using or want to use withdrawal, I hope you'll appreciate their disclosure and honor it with kindness. The destigmatization of this method, I cannot underscore enough how important that is in people's willingness to talk about it, learn about it, and use it correctly. And then discuss male partner education and abilities. So it's not as common for males to discuss contraceptive options with providers, but in the event that your client is male, it is appropriate to ask about any previous experiences they've had with withdrawal or with ejaculation control. Have they had any challenges or difficulties? Do they feel confident in their abilities? And do they have the support from their partner in trying this method out? And then if your client is the person who's relying on their partner for use of this method, you can ask similar questions. What types of experiences have they had with their partner using withdrawal or ejaculate control to date? Do they feel confident in their partner's ability to withdraw successfully? And then providing some education. So it's pretty straightforward to educate someone on the 2 rules for withdrawal. However, some tips might be helpful. It could be helpful to make sure that the person knows the anatomical terminology of the vulva and the vagina so that they're really clear on what they need to avoid when ejaculating. And then providing some sort of handout or other information about withdrawal can be helpful so that a client could take that home and share with their partner later. Discussing a learning period and support for learning. Like I've just said earlier, you can let your clients know that withdrawal is a skill. It might not be perfect on the first try. Generally, for any skill, it takes about a month to learn a new physical skill. And while there's no research on how long it takes to learn the skill of withdrawal, it might be advisable to have clients practice for a month using condoms before using withdrawal. And then offering emergency contraception in the event of an accident is important. So having that EC on hand or a prescription for the EC can support people who want to use withdrawal. And then considering a dual offering of any other methods that might be supportive. So, an FABM or other condoms, and discussing backup or alternative methods. So as with any method, there are going to be people who try withdrawal and find that it's not for them, and helping people have a plan for what they'd want to do if this method doesn't end up working can ensure that there's a transition in the event that that happens. So does anybody have any questions about withdrawal for me? Okay, so some final take-home points I would feel great if you left with today are that these methods are legitimate and there are good reasons that people might want to use them. Fertility awareness methods are a group of methods with different rules and signs and symptoms that they collect. Try to discuss them where you can as individual methods rather than as a group, unless you're just doing a generalized counseling. And then lactational amenorrhea can be an effective way to prevent pregnancy for people who want it, but it's most likely to succeed if parents have support for both breastfeeding and an alternative option before they go into parenthood. Withdrawal is a skill that people can get better at. So those are all my points. I'm going to make sure that we send out some of the literature that I've discussed along with the slides from today's session. And if you're interested in learning more about fertility tech and apps and don't mind listening to me drone on for another hour, feel free to tune in tomorrow from 12 to 1 for a more in-depth look at this aspect of fertility awareness. So any other questions people have?
This is Sarah. I have one more question.
Yeah, absolutely.
If I can turn my video on. So a lot of times people tell me they use the withdrawal method, or like they'll say he takes care of me basically. And
right.
I haven't, I don't usually delve into that more, but it sounds like you're saying it would be worth a quick, like, let me give you some tips on how to make that more effective. I mean, what do you think about that?
Yeah, I would say that if somebody discloses that their partner is using withdrawal, I would just say, how's that been going for you? Do you feel like they're able to do that successfully? Would you like any EC? Would you like to just make sure, I would just have them make sure that their partner is using the restroom between sex acts. I think those things could be, 15 seconds of a, of a conversation, but it might give them additional options to have those conversations. I do think that just really, and I have no doubt that you're doing this, just really acknowledging that that's a thing and that it's okay, I think is the most important thing. There's so many studies right now that have found that people are underreporting withdrawal or not telling their providers about it. So I think it's great that people feel comfortable enough to tell you that they're using it.
So one more follow-up question. This has come up before where you can reasonably rule out pregnancy if someone's using another method, etc. And if someone's reporting one of these methods, are we good with reasonably ruling out pregnancy? What are your thoughts on that?
If they're using withdrawal, I might ask a few questions around cycle information, and that doesn't necessarily mean a person would be familiar with their cycle, but I would say that it just depends on, I would ask if they know their last period start date and utilize that as a way to also rule out pregnancy for withdrawal. Just because, and I might ask them how long they've been using withdrawal as well.
And if they use it every time.
Yeah, and if they've used it every time, and people typically aren't necessarily truthful with that, but if they, one way to really assess that is, if you've been using withdrawal for a year, we could be reasonably assured that your partner is using it correctly. They don't have necessarily sperm in their pre-ejaculate. If they've been using withdrawal here and there without, irregularly, or if they use it sometimes, I might do another pregnancy verification, or you rely on other ways to verify that they're not pregnant. Just because it's hard with withdrawal. Few people use it as their only method. A lot of times they use it in conjunction with condoms, or they use it in conjunction with FABMs, or they're using it at different times in their cycle. And all of that can impact, whether or not it's successful. So it might be just something to dig a little bit deeper in. How long have they been using it? Are they using it every time, or are they sometimes using condoms? And then, kind of going from there. That's what I would recommend.
Thanks, that's really helpful.
Of course.
Excellent. Those are some great questions.